as Dr. Bailey mentioned, that we need to stand up for what we know is right. And sometimes that can be really uncomfortable. Like for me, I've been a nurse in Texas for 23 years, and really, I am so uncomfortable up here right now. I would rather give every one of you an enema than be up here talking. So bear with me. You won't get the enema, but go easy on me here. So this picture is of my dad and I, probably just about 6 months before he died. And I want to thank Kevin and Health Watch USA for giving me this opportunity to share my dad's story. My dad was a hardworking middle-class man. He had calloused hands but a soft heart. His favorite color was navy, and he went nowhere without his grizzly tobacco. My mom could be loading the car, getting ready to go to the hospital, and they had to rush, and my dad would be in the car honking the horn at her, and they'd back out, and he'd touch his pocket. Well, I've got my grizzly. You know, my mom's worried about the medicines and everything else, but as long as he had this, then he was going to survive. My parents were married for 49 years and 4 days. They had 2 daughters. I have a sister 3 years older than me, and 6 grandchildren. Rules were enforced in our house, and there were definitely consequences. There was a lot of love as well. I don't think a night went by that my dad didn't tell me he loved me. My dad's grandchildren were his most precious treasure. Say that 3 times fast. He didn't miss not one of their events. If his grandchildren were involved in functions, he was going to be there. In fact, he made his surgeon change one of his doctor's appointments because it was going to fall at a time frame where he would miss his grandson's high school graduation, and he said he wasn't going to do it. January 1st, 2014, began a roller coaster ride through healthcare our family never thought we would have to endure. My dad was admitted with possible infected hardware to his right knee. It had already been replaced one time before, so we knew that this was not going to be a good situation if it had to be replaced. We knew they couldn't replace it a 3rd time. The sequences which followed were nothing short of a nightmare. From January 1st to December 1st, my dad was hospitalized 100 days in that 10 months. He was on 11 different nursing units, and he had 15 surgeries. The first delay in care was the diagnosis of a post-op ileus. We had let them know pre-op and post-op that my dad had developed ileus with his other knee surgeries. They assured us it would be fine, they'd be watching and taking care of that. Within 24 hours, he started to show signs of developing an ileus. It took us 12 hours to convince them to get an order for a KUB. Once the KUB came back, he did in fact have an ileus. We got an order for an NG tube. And it took 13 hours for that nurse to put the NG tube in. And she didn't do it until my dad had projectile vomiting and went into hypovolemic shock. The second delay in care was just 6 days after the first one. My dad's condition started declining, and the nurse had called the doctor, and he said, I think we need to send him back to ICU. It took 5 hours from the time that the ICU bed was ordered to the time my dad went. There were 5 patients ahead of him, and the only reason my dad got bumped is because I called everybody up to the CEO and I threatened a lawyer. When my dad got into the ICU, instead of just needing a BiPAP, he needed to be intubated. He was put on CRRT, which is a continuous dialysis for those that don't know. He was on every medication you could dream of, Levophed, leave him dead. They told us clearly if he survived, it would be a miracle. Let me tell you, that darn Pollock survived. Ultimately, he did go home after that hospital stay. A hospital stay that should have been 3 to 5 days was 36 days because of the 2 delays in care. The final delay in care was Thanksgiving, 10 months later. He began running fever at my aunt's house on Thanksgiving night. I told my mom she needed to call his physician. They said he needed to come to the hospital and admit he probably had a pneumonia because he had been fighting a cough for the last week. It was the worst case scenario. All the holes in the Swiss cheese lined up, and there was no hope. He was admitted with pneumonia, and within 24 hours, I started getting a bad feeling that he had a new onset congestive heart failure. I let the nurse know, which I know is not good, but I let her know I was a nurse, and 15 of my 20 years had been in cardiac, and that I was 99% sure that he was in congestive heart failure. It took about 12 hours for us to get them to finally call his cardiologist and get him to the ICU. Again, the only reason he was moved is because we threatened a lawyer. Within 24 hours in the ICU, my dad wasn't responding to anything. His poor 72-year-old body could not make it through a 3rd delay in care. My dad was not retired, not one day of his life. He worked up until his death. After my dad died, I knew I had to return to bedside nursing. I needed a better understanding of why so many things could go wrong to one person and why it had to be my dad. I had been in leadership the previous 11 years and had always prided myself in staying in tune with my staff and knowing what was going on at the bedside and rounding on my patients, and I just really thought I was all that. I had no idea. As a leader, I had no idea that preventable medical harm was the 3rd leading cause of death. I had no idea that higher rates of errors were associated with nurse-to-patient ratios above 1 to 5. Within just a few months of returning to bedside nursing, it was clear that the demands on the bedside nurse were unrealistic. And in an effort to bring purpose to my dad's death, I knew I needed to be part of the change that needed to occur in nursing. I knew that I needed to educate on the impact that nurse-to-patient ratios have on patient safety. When I'm fortunate to have 5 patients, I know my patients. I know their medical history, I know the medications that they're on, I know their family members, I know their role in their family as that family member, not a patient. And I can catch subtle changes and I'm going to act on them right away. When I have 6 patients, I'll know my patient, I'll know their medications and their diagnosis. I may know a family member, but probably not. And I will have to be very deliberate at making sure that I catch subtle changes because we are so easily distracted with tasks. When I have 7 or 8 patients, which is the norm, 90% of the time I have 7 to 8 patients, and this is on a med-surg type floor, they all start looking alike. I spend a great deal of my time prioritizing who's the sickest and who's the most unstable and what I need to do for them. I don't always remember why they're in the hospital or what medications they're on. I often know them by a room number, and that's embarrassing to say. I'm going to miss subtle changes and I'm going to make medication errors. The patient that's going home that needs a lot of discharge instruction, they're barely going to see me. In 2004, California mandated ratio legislation went into effect. No other state has followed California's lead. you can read that there are 7 other states that have modeled legislation by ANA, American Nurse Association, safe staffing principles. I'm here to tell you they sound really good and they read really well, but they are not done effectively. They are not monitored. Texas happens to be one of those states. And I was a leader in Texas when this was initiated, and I didn't know about this law until I went back to bedside and started researching. There are 2 bills that have kind of been sitting in committee for many, many years. H.R. 1602, Representative Jan Schakowsky of Illinois, and then S-864, Barbara Boxer of California. These are the bills that we're pushing to get made law. Research linking safe staffing to patient safety, and these statistics are pulled from the Linda Aiken study on California after they had gone to mandated ratios. The difference between 1:4 and 1:8 nurse to patient ratio is approximately 1,000 deaths a year. Adding 1 patient increases the odds of readmission for heart attack 9%, heart failure 7%, and pneumonia 6%. Patients on an understaffed unit have 6% higher mortality rate. And if even just 1 RN FTE was increased for 1,000 patient days, the mortality rate would drop by 4%. In 2015, Massachusetts Nursing Association did a survey with their nurses, and the findings are not good. 50% report injury or harm to a patient due to unstaffing. 61% reported medication errors due to unsafe patient assignment. 81% report RNs don't have time to educate patients and provide adequate discharge planning, which I had explained a minute ago. And 86% report RNs don't have time to properly comfort and care for patient, family, and the patient. And that's what we went to nursing school for. Is to comfort and care. And all of these, I share all of these with you. I think whenever we see nurses on strike and picketing and different things like that, to the lay person, it looks like, well, maybe the nurse is lazy. She just doesn't want to, they're complaining about too much work. And for me, it's about going home and putting your head on the pillow and being ashamed of the profession that you're in, feeling like you sold your soul to the devil, which is the almighty dollar, and always feeling defeated. I don't know of a day that I get home that I feel like I did everything that I said I would do when I became a nurse. As nurses, we're the hands that touch the patients the most. We're the healthcare workers delivering the majority of the care. We're the last safety check. How can we demand better for our patients? As we did last year, we'll be meeting again May 5th, 2017. Nurses from around the country will gather at the Capitol to push for passing of the 2 bills that I mentioned. This is a picture from us last year and the website where more information can be obtained, and we welcome family, friends, everybody. We have patient advocates that attended last year as well. Equally as important as safe staffing is allowing the patient and the family members to be part of the care. Their involvement's a vital role. With each one of my dad's delays in care, my mom told them something's not right with him, something's not right with his breathing, and they didn't listen to her, and she was right every single time. This is just a sweet message between my dad and I when he survived that second rapid response. Prior to my dad's experiences, the families that would take notes and quiz me really annoyed me, and I'm embarrassed to say that. Now I take the time to thank them. I let them know that their loved one is alive because they are there and they are keeping on top of their loved one's medications and test results. I thank them for being my second pair of eyes. We need to encourage our patients and family members. Don't ever leave them alone, not ever. Their life depends on it. Take notes, keep a journal of events, Speak up when you notice changes. Often I would hear my mom say, why aren't they seeing this? I'm not the doctor. I'm not the nurse. Why aren't they seeing this? And I would tell her, you're the expert in Daddy. You know Daddy better than anyone. Always have people with you to hear information when you're given, like when you're given immediately post-operative or post-procedure or appointments like were mentioned earlier. Be prepared, have questions ready, and keep asking the questions until you understand what's being said. Visit loved ones often in the hospital. It makes a difference for many reasons. Though it's not fair, we all know that the patients that have the families come off and the staff are on top of it. They're going to make sure everything's done because they don't want that crazy daughter that's a nurse coming up here bitching at us. And that was me. Which my dad didn't help much. He shouldn't have told, but anybody that walked in the room, he asked them how long they'd been a nurse and if they had their bachelor's. And then he'd say, well, my daughter's a nurse. She has her bachelor's. She's been one for 23 years. So they hated me before they even met me. Also, hospitals can be a lonely and scary place. Frequent visits remind them of their worth and their value and why they are fighting like they do. And when they know their value, they do fight. They have a strength within them that can't be explained. My dad beat the odds the first 2 delays in care. And as I mentioned, a hospital stay that was supposed to be 3 to 5 days ended up 36 days. This picture is when we came home from the hospital on day 36. We have a very large family in a small town in Texas. And everybody was there for the celebration. And this is my cousin Roy doing the armband cutting off all the armbands that my dad had accumulated over the 36 days. Unfortunately, he wasn't able to survive the 3rd. And when I saw his death certificate and it had listed congestive heart failure, I knew it. Legendary Stanford professor Arthur Bloomfield says that there should be a plaque at the entrance of every hospital, and it should say, there are some patients whom we cannot help. There are none who we cannot harm. Thank you.